I'll just kind of briefly introduce child and adolescent mental health. Now, obviously, it's a very important area of focus. Basically, yeah, it's a significant aspect of a child's social and cognitive development, and addressing difficulties at this stage can reduce the future severity of mental health and even medical issues. Right. Yes, it works. Okay. So on this slide, you can see some statistics from the World Health Organization. And what I'll also mention is that children with mental disorders also face major challenges with stigma, isolation, and discrimination. And I want to emphasize that the period of adolescence is considered a high-risk one for the development of mental illness because serious symptoms, such as psychosis, can be exacerbated during this period, especially as adolescents are introduced to and confronted with a number of psychosocial difficulties, some of which are unique to this developmental stage. It's also important to know the association between mental health and physical health, which has also been well established, in particular with chronic diseases. Without proper intervention and lack of personal resilience, adolescent experiences such as peer pressure, substance use, bullying, and stigma can lead to unhealthy coping strategies and lifestyle behaviors, which can then develop into CNCDs in adulthood. So the population which the Child Guidance Clinic serves is a unique and significant one. Now, the clinic provides diagnostic and intervention services to children and adolescents who experience emotional and behavioral problems. It takes a multidisciplinary team approach to patient cases, and we also collaborate regularly, as was mentioned before, with the Specialty Community Pediatric Clinic at the SWRHA, whereby consultation and expertise on cases are shared. This relationship has benefited the clinic because through this collaboration, the clinic now offers specialized diagnostic and intervention services specific to autism spectrum disorder. So in addition to patients from the Southwest region, our clinic also accommodates patients who reside outside of the Southwest region, such as in the areas of Rio Claro and Mayaru, and even Chaguanas, because traveling to the clinic in South can be more convenient financially and otherwise for these persons. The clinic also embarked on a number of community outreach seminars and workshops, and this year staff has been involved in presentations regarding social media and online use, self-esteem, sexuality, and parent training. And one of the highlights of these community outreach seminars has been a series of autism parent training workshops, which received overwhelmingly positive feedback from the parents who attended. So one of the clinic's objectives is to record and conduct relevant patient information and analysis. And the information presented this morning represents the clinic's half-year review of patient demographics and diagnoses. So for the first half of 2016, the total number of patients benefiting from our services was 389. So this figure comprised of 119, or 31% of new patients admitted to the clinic, while 270 patients, or 69%, attended the clinic for follow-up sessions or revisits. And these 270 patients would have been admitted to the clinic prior to 2016, but still benefit from our services this year. Demographically, more male patients were seen by the clinic than female patients. Males accounted for 61%, or 236 of all patients seen. It was also observed that the clinic saw more adolescents between the ages of 12 to 18 years, while children 5 but less than 12 years of age accounted for 43% of patients. So an analysis of the active patients based on area of residence was also carried out. And according to our statistics, it indicates that the majority of the clinic's patients reside in the area of San Fernando and environment, as about 42% of patients. And this was expected given that San Fernando does have the highest distribution of 5 to 18-year-olds in South Trinidad, and also the clinic is located in San Fernando. Of note, though, was that the second largest group of patients reside in Siparia, an environment of 25%. And this was surprising because Siparia has the fourth largest population, which you can see on the graph on the left, the fourth largest population of 5 to 18-year-old individuals in South. Now, one of the possible reasons for this seemingly overrepresentation of adolescents from the Siparia district may be because of the presence of a satellite child guidance clinic at the Siparia District Health Facility, where we have a psychiatric social worker there 2 days for the week. And this has allowed for easy accessibility to the clinic services for residents and for organizations there that we liaise with. And it was also observed that 2% of active patients for 2016 resided outside the boundaries of the Southwest region. So patient diagnoses at our clinic are divided into primary and secondary diagnoses. The primary diagnosis refers to the diagnosis given after assessment of the patient, which is the main focus for treatment intervention. Secondary diagnosis refers to the diagnosis that coexists or is comorbid with the primary diagnosis and which also requires intervention. So from the chart, you can see that the majority of active patients at our clinic received a primary diagnosis of attention deficit hyperactivity disorder, or ADHD. Now, these diagnoses given to patients are consistent with the classifications used in the 5th edition of the DSM, with the exception of behavioral problems and the, as you would see, another category. Now, to clarify, the categories of behavior problems and other are used to describe characteristics of patient behavior that do not meet the criteria for a DSM-5 diagnosis, but which are sufficiently disruptive to the patient and their family. And another note, the other diagnosis also refers to patients who have been diagnosed with various disorders acknowledged by the DSM, but when counted individually, they are statistically insignificant, so they were therefore combined into this other category. So these disorders would include things like adjustment disorder, trichotillomania, somatic symptom disorder, suicidal self-injury, and suicidal behavior disorder. You should note that the second highest group of diagnoses was oppositional defiant disorder and behavioral problems and conduct disorder, and the other represented the third highest or the third most frequent diagnoses. Okay. Primary diagnoses among new patients was also analyzed. So again, new patients meaning patients admitted in 2016. So among the 119 new patients, it was noted that the majority diagnosis within this group was actually in contrast to that of the total active patient group for the same period. So the largest majority of diagnoses fell within the other category with 25%. So as ADHD was the most common primary diagnosis, we decided to take a closer look in this area. So global statistics indicate that ADHD prevalence ranges between 5 to 7% of the population and is more frequently diagnosed among males than in females. At Child Guidance, 121 patients, or 31%, were given a diagnosis of ADHD as either primary or secondary diagnosis. Out of these 121 patients, 78% or 94 had a primary diagnosis of ADHD, while 22% or 27 patients had a secondary diagnosis. Of these 121 patients, 87% or 105 patients were follow-up patients, while 23% or 16 patients were new. Alright, with respect to sex, among this ADHD group, 79% were male patients, while 21% were female. So this is consistent with international statistics, whereby there is a higher reporting of males with ADHD. With respect to age, we saw that 60% of patients who were diagnosed with ADHD fell within the age group of 5 to 11 years, while 40% were within the age group 12 to 18 years. The reasons for this could be, for the higher rates of ADHD in the 5 to 11 age group, could be because of the fact that in the last 5 years, more children have been diagnosed with ADHD, and also within the adolescent age group, a lot of children may have defaulted after receiving intervention, especially if their hyperactivity became more controlled and manageable. And again, with respect to districts, to observe that the majority of patients diagnosed with ADHD at the clinic fell within San Fernando and environs, followed by Siparia, Princeton, Couva, and Point Fortin. And given the above stats, the prevalence of ADHD among 5 to 18-year-old individuals within South Trinidad can be projected to be 0.13% of the population in South. And this is significantly lower than the average ADHD prevalence rates observed internationally. So it implies that the diagnosis of ADHD appears to be significantly underdiagnosed. However, it should be emphasized that of those persons seeking psychiatric treatment for mental health disorders at the clinic, the percentage of those diagnosed with ADHD is still considered to be high. With respect to comorbidity with ADHD diagnoses, the most frequent comorbid diagnosis that we saw was oppositional defiant disorder and conduct disorder, followed by specific learning disorder, and this is consistent with international research. Okay, with respect to further clinic observations that we saw for the first half of the year, we actually saw fewer referrals for test anxiety. In the past few years, the clinic has actually observed a pattern whereby in the first half of the year, as national examinations such as SCA and CSEC and CAPE approach, there will be an influx in the number of referrals related to anxiety, the majority of which would directly be related to the stress of upcoming exams. It was noted, though, that this year the number of referrals for this particular type of anxiety was fewer, although the rate of anxiety referrals was consistent with previous years, and this could possibly be due to an increased presence of guidance officers and school social workers who probably would have addressed that issue of test anxiety. We also saw a high frequency of referrals for self-harm and parasuicide. And a brief analysis of the cases at the clinic so far, we saw that 5% of our patients have a history of self-harm. That was about 19 patients. There were more females than males. All were between the age range 12 to 18 years, with the average age being 14.6 years. With respect to child abuse, because of the significance of having such a history, we also looked at patients who had a history of child abuse. We saw that 3% or 13 patients have a history of child abuse at our clinic. 11 of those patients had a history of sexual abuse, and the majority of them were female. Other recent observations that we've seen post-June of note indicate that we've been getting frequent referrals for trauma due to abuse, both for children who are a victim of abuse and witness to abuse. We're also seeing a lot of cases with complex psychosocial factors and histories which exacerbate mental health issues and which require complex and multiple forms of intervention. We also see a lot of emotional issues triggered and again exacerbated by family dysfunction. And we're also seeing frequent referrals for substance use and abuse, especially with respect to marijuana use. And in thinking of how we move forward, these statistics can guide planning and policy at a national level, especially regarding child and adolescent mental health. There should be a more consistent and significant drive towards mental health promotion and awareness through public health campaigns. I'll also advocate for more funding and staffing and ongoing training for relevant agencies. There should be a push towards research and analysis of issues which affect children and adolescents, especially in this technological age. There's a lot of bullying, social media use, self-esteem, coping skills, same thing that was mentioned before. We have to see how that's affecting our children's mental health. I also would like to see if more effective support systems need to be implemented. This can be done through the involvement of a primary agent in a child's life, like through parents, through parent training programs, through schools, or school social workers and guidance officers. We can also probably implement peer counseling programs. Once again, I don't know how many schools have that in effect now. And again, there should be improved collaboration, networking, and communication among all agencies involved in child and adolescent health and well-being, because I think that's desperately needed right now. And lastly, regardless of diagnosis, what we have consistently seen at the clinic is children and adolescents having difficulty coping with overwhelming environmental factors, ranging from family dysfunction and peer pressure at school, bullying in all forms, social rejection and exclusion. And recent reports in the media seem to suggest children seem to be using extreme measures to cope with these stressors, such as suicide and self-harm. So I think teaching children how to adapt to adverse life events and engage in healthy coping mechanisms is of paramount importance right now. Okay, so thank you very much.